about this very pertinent issue. I have with me Dr. Tota Narendra Kumar, who's a consultant medical oncology, hemato-oncologist, and stem cell bone marrow transplant specialist at KIMS Hospital. Welcome to the discussion, sir. Thanks for joining.
Thank you. Thank you. Thank you for inviting.
So I'll just start without much delay. We would want to take as much information from you as possible. So I'll first start with the basic question, which is about, because we are specifically talking about lung cancer staging. So could you please explain what staging is and why it is significant in the management of lung cancer?
So basically, lung cancer treatment depends on the staging. So staging, what does it say is, what is the spread of the cancer? Suppose if it's in the lung, we need to know whether it is in the place where it has started, or it has spread within the same lung, or the opposite lung, or different parts of the body. Suppose if it spreads to different parts of the body, we call it a stage 4. So then management changes, and the outcome, that is the survival spans, are different for stage 4. And similarly, if you see and pick up a patient in stage 1, stage 1 means, simply to make you in a broader sense, to make you understand, is stage 1 is in a place where it has started. Stage 2 is it has little spread beyond the site of origin, but on the same side of the lung. And stage 3 is involving the chest, the lymphatic drainage system, we call it as. So all the lungs drains into lymph nodes. Lymph nodes are the glands of our body which collects the white blood matter, which we have like white and red blood. The white blood flows through the lymph nodes. So these lymph nodes are meant to be as a drainage points. So if these are involved, we call it as stage 3, that is beyond the site of origin. And stage 4, as I explained, it is spread to the different parts. So these are very important in sense to know the spread, so that we can decide the treatment. And when patients obviously expect the survival spans, and based on these stages, we can give a clear picture that how the patient's future, that is cure, which any patient expects, that we can give a broader idea how they are going to be in future. That's the basic necessity of staging.
Right, Dr. Kumar. So I would definitely want to cover more of the treatment part further down the discussion. But when we talk about diagnosis, so what is the basic stage, and how, diagnostic modalities change according to those stages? If you could shed some light on that.
Yeah. So no patient directly comes to a oncologist, right? So whenever a patient goes to physician, 90% of the time they go to physician because of the complaints, like somebody who is having a chronic cough, which is not responding to treatment for at least 2 to 3 weeks, or patients who present straight away with cough and blood tinged sputum, and patients who lose a lot of weight without cough. Sometimes it do happen. So anything which is chronic beyond 2 to 3 weeks, which is not responding to the treatment if the already doctor has seen, or the patients who have not seen by a doctor, but they have losing a lot of weight and with blood tinged sputum, these are the subset of patients who generally go to a doctor first. So when they go to physician, what do they do? Immediately they do a chest X-ray, simplest test which is available, like 3 to 400 hardly cost. So that's the first test any doctor will do. So will it help in knowing the stage? Yes, sometimes, because suppose if the patient have a fluid in the lung, automatically it says that patient might be having a lung cancer which is already beyond local stage. So X-ray also sometimes helps. But if it is not clear on X-ray, so the doctor, what does he do? Immediately, out of suspicion, they advise most often the CT chest. That is contrast enhanced. The CT chest is the ideal test which is advised by most of the physicians. Then they have a clear picture. At least it gives the information by at least 90% of the time what we need clinically. So then they go for a biopsy. So the biopsy is the confirmation test. So for any doctor, if biopsy is not done, all the tests are only provisional, saying that he could have cancer. That's it. But without biopsy, it is impossible to say it is cancer. So once the biopsy is done, it confirms that patient is having a lung cancer. So once it is done, then the next process starts, like doing a PET-CT scan to know how much it has spread. Sometimes, suppose the patient have a headache argitinase, which suggests that patient might have the spread of the cancer to the brain, then we might be doing an MRI brain. So like that. So depending on the site and depending on the complications, which the patient presents to the doctor, we will be advising. But definitely most of the patients will be requiring a PET CT scan. MRI is always a plus or minus. If the patient doesn't have any symptoms, then we don't do it. But if the patient has symptoms like headache or vomiting, we'll do it. Once this is done, then the newer technologies will come into the scene for treatment purpose. So on the biopsy, they will be doing some molecular tests which helps in treating the patients. These are the tests generally we advise as a practicing oncologist in our clinics.
Right, Dr. Kumar. That indeed was a very insightful, uh, thing from coming from you. When we talk about diagnosis, because there are challenges, because you talked about biopsies, then of course other scans. But there is a lot of misinformation also, because I've seen people saying biopsy say cancer फैल जाता है. Yeah, so in your practice, what are some of the challenges that you have seen in patients when it comes to diagnosis, which is the most important part, because the earlier you are diagnosed, the better treatment outcomes you are going to have. So what are those challenges, if you could give us some insights on those?
So this, of course, many of my patients also ask that when we do a test, that will it spread? So basically, it's not like that, because depending on the site, the testing modality is decided. Suppose if the lung cancer is the surface of the lung, so that area is accessible by the CT guided, that is image guided biopsy. So there, the track which is done through the chest wall, this is very small, and the gun, or we call it as a gun, which is used for biopsy. So it's a typical to gun, like if you shoot it, it just goes inside, take the tissue, and the needle goes inside to the gun. So it will not disseminate basically. So if it is early stage, we are concerned with the spread. Suppose if it is late stage, we are really not at all worried. So especially in the early stages, we will be using a CT guided biopsy with a gun. Suppose if it is not on the surface of the lung, then if it is in the mediastinum, that's I said the lymph nodes, the glands, if they are involved, they go through the trachea. That is the bronchoscopy. They do it. They just go inside the trachea and near to the lymph nodes. Through that area, they insert a needle and then take a biopsy from that. So these are the common modalities. So we don't need to worry about the spread, because it rarely happens. But this is mandatory for us to know the diagnosis and spread. So they should not be having any confusion, because without these investigations, you can't treat the patient. So do not worry about the spread. Suppose if it is diagnosed to have stage 1, then your total out the method is treatment is different, and the cure rates are literally high. So that's very important. So just a fear of investigation should not discourage for somebody to get investigated. And in my practice, you asked one more question is, in my practice, what are the difficulties? Basically, we face challenges in investigating a patient when the tumor is especially in the critical areas, like suppose near to the heart or near a blood vessel like aorta or a pulmonary artery, where you cannot use a gun. Like, it's a rapidly, it has got spring, and if you release it, it just goes and hit. So you can't take a risk to hit the major blood vessels. So that's the areas where it is difficult to do it. But for every area, you have an alternative method. Like, if it is near to that area, you go through the trachea with a small needle, go it, and then take a small sample and come out. Suppose if these methods are not cannot be done, then we take the surgeon's help. They do a VATS, that is going inside the thorax, then with a needle or directly approaching that respective site, they just take a small chunk of the cancer tissue, they come out. So there are different methods basically to get a small tissue without spreading the cancer into the body. So there are different modalities, nothing to worry about that.
Right, Dr. Kumar. Coming to more, role of molecular and genetic testing when we talk about early diagnosis, and what innovative techniques are, especially with a focus on diagnostics. What can we expect in future, and how things are changing when it comes to diagnosis, especially?
Yes. So still the lung cancer most important and gold standard is biopsy itself, as we are discussing since the beginning. So until that is done, there is nothing to be going forward. So once the tissue is taken, the most important is it has to be observed under microscope. Then the type of cancer will be decided. Like there are different types. Like it could be adenocarcinoma. That's the commonest cancer which we see in practice. Then comes the squamous cell carcinoma, which we generally we see in smokers. Then there comes the small cell cancers, which again we see in smokers. So these are the generally varieties of 1 minute. Oh, sorry. So that's how we take the tissue and diagnose under microscopy. Once this is done, based on the histology, we will be deciding to send some tests. Basically, these tests are utilized for the treatment sake. Like there are a lot of new medications available in the market. Since last maybe 10 to 15 years, probably it's around 15 years, because the first targeted therapy which has come into the lung treatment, that was Geftinib, which was when I was doing my fellowship in 2010 or 12. So that time the first drug was launched. So since that time, there's explosion of drugs in treatment of lung cancer. There are almost like 7 to 8 varieties of different drugs available in the market. So to use these drugs, we have to know exactly what type of changes, that is genetic changes, has happened in the lung tissue, cancerous tissue. Then we can select the proper drug. So these newer tests are there in market. So we will be deciding these tests and which type of cancer it has to be done. Suppose if I get adenocarcinoma, I'll be selecting a different type of the test. If I see a small cell, different panel. If I see a squamous, different panel. But most of the time we'll be doing all the tests in all type of varieties. But in adenocarcinoma, you will get, are expected to get more positivity in adenocarcinoma. So these are basically the tests which we use. And to be precise, to know what type of test we use, there are different types of tests we use in a laboratory, like DNA sequencing. If you're looking at specific mutation, now there is latest modality, we call it as NGS technique, that's next generation sequencing, which has got advantage of picking all types of mutations or lung cancer genetic changes which is seen in the lung cancer. But it takes a little longer time, like 3 to 4 weeks, but you get the maximum information. But this is the costlier test. It costs you somewhere like 70 to 80,000 to know exactly in detail what is happening in the lung tissue. So there are other tests like FISH. It's a genetic test which is used in our own centers, and IHC. These are the broad modalities of test for you to know exactly the drug which is beneficial. So these are the latest techniques which are available in the market.
Right, Dr. Kumar. Coming to the treatment part, once the staging is done and, there is this correct accurate diagnosis that you have, how do treatment modalities vary depending on the different stages that?
So again, as I said, there are 4 stages. Suppose if the patient is in stage 1, stage 2, surgery is the best modality. Here, radiation or the newer targeted therapies like TKs, we call them as EGFR mutation. That's the only drug which we use here if it is positive. Surgery is definitely the best treatment modality for 1 and 2. If the patient is stage 3, where it's a doubtful area of stage 3 or different to stage 3, if it is doubtful, then the surgeon goes inside, sees, and they do sampling of the lymph nodes. If it is stage 3, then they come out after resecting the tumor. In stage 3, we need to give a radiation, but with the availability of new drugs, the TKs, we call them as, we are using those drugs once the surgery is done. So radiation or the new drug can be used. So 1, 2, chances of cure is very high. Surgery is sufficient. 3, surgery, chemoradiation with tablets, and sometimes there is an immunotherapy option also for stage 3. So if your diagnosis is stage 4, then you don't have a surgery option unless otherwise they are causing any complication like pressing a tumor on the nerve or pressing a tumor on the blood vessel or a bone, which is difficult. Like, or they may be having a tumor which is causing, or it could blow up and cause a pneumonia. Those sort of things which sometimes, rarely, we require surgeon's help to put a tube into the chest or resect the lung. So the certain areas where the surgery is done in stage 4, very few of the times, and radiation also in lung cancer stage 4, few times, like bone spread, which cause severe bone pain. or the cancer which has spread to the spinal cord, which can cause our loss of power in the lower limb suddenly because of the compression of the spinal cord. There we'll be using radiation. So there are certain areas where we utilize surgery and radiation in stage 4, but otherwise chemotherapy and oral drugs. But in stage 1, stage 2 surgery, stage 3 surgery, radiation, chemotherapy, stage 4 only chemotherapy. This is how we approach a patient.
Right, Dr. Kumar, that was a wealth of information coming from you. Coming to the post-treatment, life of individuals, because it is not that you got treated, you got well, of course, you can go back to your, normal routine. But what are some of the ways in which post treatment works, and when do they need to follow up? What are some of the risks that they might have, and they have to make those small changes in their lifestyle? Please enlighten.
So again, whatever the follow-up treatments, whatever it is, they're purely decided on the stage. So suppose, as I said, in the stage 1, suppose if the patient undergoes a surgery and they doesn't require any further treatment, they will be followed up for first 2 years every 3 monthly, because that's the area, that is the first 2 years is the time where whatever the risk is there, we generally see the relapse risk in the first 2 years. This rule applies for any cancer also, but in the lung cancer, first 2 years are carefully followed up, and most of the time we'll be doing a routine general X-ray, and sometimes we'll be doing a CT chest also for the follow-up. And if you're coming to the stage 3, here the cure rates are very less, but you can have a decent life. Like I have seen a patient of my own since last 7 years. He's a stage 3 and he's doing very well. Recently, he came back with a breathlessness and chest pain. We did tests which are little doubtful, but I still suggested him for a follow-up. So we are not doing anything for him. But if you are coming to the stage 4, then here survival depends on the molecular test which we have discussed. Suppose, for example, if you get a EGFR, it's a mutation. If it is positive, we have seen patients surviving beyond 5 years or 7 years sometimes. But averagely, what we see is somewhere like 6 or 7 months above to the max around 5 to 7 years we have seen. Similarly, there are different tests like ALK mutation. These patients are also doing very well because there are very excellent drugs are available in the market. So similar way, there are immunotherapy. If the immunotherapy works for stage 4, they have a very good span of life. It can be 2 3 years and beyond also. So similarly, there are other drugs like there are mutations like BRAF mutations or KRAS mutations. There are RET mutations, ROS mutations. So there are different mutations based on the tests and the drugs which we use. They are giving a good quality of life. So the follow-up again depends on the drugs which we are using again. It is based on the stage. The follow-up is decided, and especially when you come to the stage 4, the drugs which you are using makes them how frequently they have to follow. Suppose if I'm giving an injection-based treatment like chemotherapy, they need to come to me every 3 weeks. Suppose if I am putting the patients on the oral tablets, for first 2 months, they need to come to hospital every 15 days to monitor the side effects. Then after that, every 3 months, they will come to the hospital with a PET CT scan or a CT scan with an interval of 3 to 6 months, depending on the requirement sometimes. But first 1 year, 2 years, we'll be doing very frequently PET scans for especially stage 4. So if everything is going fine and the patient is comfortable, sometimes once they cross 2 years, we make them to come every 6 months also sometimes. If we assume that patient is under excellent disease control, patient is doing very good, they are able to continue their life, routine jobs, routine work, then we'll ask them to come less frequently because so though they don't get disturbed in their routine daily life. So that's how we decided.
Yes, Dr. Kumar. Coming to, when we talk about how early detection is important for improved, treatment outcomes. So when we talk about screening for high risk individuals, what is the role of screening, and who would you put under the category of high risk individuals? How is that, decided? Please.
Yeah. So basically, in lung cancer, there is no standard screening recommendation as such. Standard screening methods are only for breast cancer, then cervical cancer in females, and people, male or female above, once they are 50 years, you can do a screening for colonoscopy, with colonoscopy for colon cancers. And in males, again, we have a screening technology for the prostate cancer. So these are the only diseases where we have a proper recommendations for screening. And if you come to the lung cancer screening, there are controversial data, and depending on the country where you are, there are recommendations. Suppose you are in Western countries, there the low dose CT scan used for a screening. Especially it is done for high risk individuals. Who are high risk individuals? Who are smokers. Like suppose somebody is smoking two packs per day for 10 years, we call it as 20 pack years. Suppose somebody is smoking one pack per day for 20 years, then also we call it them as a 20 pack years of smoker. So any patients who have 20 pack years of smoking history, generally as a medical site or from a doctor's viewpoint, they are considered as high risk patients. Or patients who are already have a diagnosis of stage 1, stage 2, who underwent surgery, they are also considered as a high risk individuals because already they have one lung cancer. So these are the subset of patients, and patients who are having a smoking history, not to the up to level of 20 pack years, but whose lungs are affected. We call it as COPD, chronic obstructive pulmonary disease. So when these patients develop these changes in these lungs, these are the patients who require a follow-up. And as far as my knowledge is there in India, I don't know whether there is a recommendations for lung screening. But in India, if I get these sort of patients, but definitely I'll suggest a screening for these patients. Because of this technology, that is low dose CT scan, what is different, how it is different from the routine CT scan? I'm not sure exactly. They use 1 or 2 centigrade dose for doing this scan, but definitely much lesser than the routine CCT scan, which is used routinely for staging. So these used for these patients as a screening modality. The basic intention is giving less radiation exposure because they're already at risk of cancer. So giving lesser radiation dose, but simultaneously picking up the Perley. Suppose if you see any suspicion lesion in the lung on screening, they will be done again in next CT scan in next 6 months. So once it is suspicion is ruled out, or if it is proven that it is non-cancer, again they go back every year. Otherwise, they have to be screened for 6 months, at least for 1 or 2 years. Then they go back to the routine regular screening. Other than this, it is not recommended for any patient because each CT scan has got very high radiation dose, and that itself can cause cancer. So I don't recommend as such any screening for any individual unless otherwise strictly recommended by the doctor. Nobody should get by themselves. Like you can get a scanning for a mammogram for breast cancer by any individual, or a pap smear by any female individual without a doctor recommendation also. But these CT scans should not be done without doctor recommendation.
Right, Dr. Kumar, that was an insightful overview. Coming to the last part, because you've talked about how, smoking is a major risk factor. So if you would want to give, an advice to our youngsters who may be, watching us today. So when we talk about moving towards that, though it's not 100% preventable, but since smoking is a major risk factor, what would you tell the younger audience with us today?
So important point which I'm going to say is everybody has to remember is we see lung cancer in smokers and non-smokers. So there are subset of patients who come to my OP. They argue that I'm smoking, okay, I got cancer, but what about the other people who are non-smokers getting cancer? So why are you saying me to stop a smoke? So that's a constant thing which are the smokers will argue with the doctor. So the important point here you need to understand is, suppose if you see two individuals, smoker, non-smoker, how they are different and what is the risk they're going to get a cancer. If you understand this point, then you will understand why you need to stop smoking. Suppose if you're non-smoker, if you take into consideration, there is 1 to 2% chance, even in non-smokers, to get a lung cancer. But if you see a smoker who have smoked for 20 years, like I said in the previous slides, like 20 pack years, these patients will have a chance of getting a cancer almost like 30% more than a non-smoker. So then, if you understand this point, nobody should argue that non-smoker has got a cancer. Why should I stop smoking? So this is a very important point to understand. It's like, going in a road and a footpath, still you can have somebody hit you by a vehicle, and the person who is exactly walking opposite to a truck. This is how you can understand. You should understand. So that's the important thing. So that should make you compulsory to encourage them for stopping smoking. How it can be done in a best way? There is a study conducted by as far as it was in Europe. So what does the study say is, if somebody want to stop the smoking, the best way is to do sudden stopping cessation. That's the best modality. But for that, you need to prepare your mindset. And without the patient mindset preparation, patient cooperation, patient family cooperation, it is impossible for any smoker to stop it. So they have to understand the severity of the problem and the risk associated with smoking, not only for the patient, for the patient family. If they understand these things, then the emotional things come and it motivates them for the smoking cessation. So the best way is to sudden stopping of this smoking. And suppose if they have a problem like craving, that's the biggest problem with this smoking. The nicotine which is in the smoke, that's the issue, that's the substance which causes them for the addiction. So if you want to really, if the patient who has decided to stop smoking, they can use nicotine gums, which can reduce their craving, but simultaneously they can escape from the smoke related complications, smoke related cancer. So if at all you can use nicotine, use it, reduce the craving, then stop it. Otherwise, stop everything. You'll have a difficulty in first 1 or 2 weeks, severe craving. You feel literally depressed. But still, if you can overcome with your family support, antidepressants, proper counselor, then you can break that smoking habit.
Right, Dr. Kumar. That indeed was an insightful discussion, and thanks for joining us today. And I'm sure our audience today got a lot of information when it comes to lung cancer, with a focus on early diagnosis, how staging, differences there, and what is the treatment modality. And it will also inspire them to move towards the preventive lifestyle, like we discussed in the last part of the show. And thanks for being with us and taking out time from your busy schedule and, joining us for this awareness session. And to all of our audience, thanks for joining us, and do keep on following our social media for more updated information on health and well-being. That's all for today. Thank you, Dr.
Thank you.